My name's Anthony Glover, and thanks to Dr. Russell Kravitz for the invitation to speak today. Um, I'm hoping I can join for some questions, but I'm having the rehearsal for the convocation today at ASC, so I've pre-recorded this talk. I'm an endocrine surgeon from Sydney, and I also have a research group in endocrine cancer and especially thyroid cancer at the Garvan Institute Medical Research and with the University of Sydney. And so in this talk, I want to talk about how we can apply genetics to the management of thyroid cancer. So I have no conflicts of interest to declare. So genetics is the study of inheritance and genes and how they interact with the environment. You also often hear about the term genomics, which is really using how we can apply study of multiple genes to medical management. And when we're thinking about genetics, it's important we consider both germline and somatic mutations. So just going back to medical school, germline mutations inherited, they're present in all cells, and they can be detected by testing of the blood or the saliva. They can predispose to cancers, and classically in endocrine cancers, we think of the multiple endocrine neoplasia syndromes or the different germline mutations that are associated with different adrenal pathologies. There are also somatic mutations which are acquired and actually present in the cancer tissue. So that's now what we hear a lot more about with molecular testing. Usually it's referring to study of somatic mutations, and they can only be detected by testing of the cancer. So they can't be detected in the blood and saliva because they're not present in all cells. So applying genetics to the management of thyroid cancer, there's two ways we do that. So mainly with the germline mutations, the most common way would be medullary thyroid cancer, which I'll go into in more detail later, and especially for the diagnosis of MEN2 syndrome and then the management of that. Increasingly, somatic mutations and molecular testing is being used in thyroid cancer management, especially for diagnosis for indeterminate thyroid nodules with the commercially available molecular testing platforms. Also screening of advanced thyroid cancer to guide systemic therapies, and in the future and being used in some centers and mainly for research is using molecular testing to predict the prognosis of thyroid cancer. So these are kind of two patients of mine showing the impact that genetics can have on thyroid cancer management. So the first case is a young man who presented with a symptomatic large thyroid cancer, which on FNA was consistent with medullary thyroid cancer. He had a high calcitonin with negative plasma metanephrines and a normal calcium. As part of his pre-op workup, due to his high calcitonin, he had cross-sectional imaging with a CT of his head, neck, and chest, which showed a suspicious right level 3 lymph node. He went on to have a total thyroidectomy, bilateral central lymph node dissection, and lateral node dissection. After his surgery, he was referred for genetic counseling and to have germline testing for MEN2. And it's all patients with a diagnosis of MTC should be referred for genetic counseling because it can have major implications for their own management and then the management of their family. And the second case, which I'll go into later, but a woman in her 50s who presents with an incidental thyroid nodule found during investigation of night sweats. She had an FNA, which showed it was a B4 or suspicious for a follicular neoplasm. She didn't have any other risk factors for thyroid cancer and worked as a voice professional. She presented with being told that she had thyroid cancer. I was very distressed by this and was concerned about the effect it would have on her life and also on her work with having thyroid surgery. And for her, we're able to use somatic molecular testing as part of the shared decision making, and she was actually able to avoid an operation due to a negative molecular testing result. So before we get into the cases in more detail, I'd just like to touch on the molecular biology of thyroid cancer. So nearly all thyroid cancers are driven by mutations in a small number of genes. So the most common gene for follicular-derived thyroid cancers would be BRAF V600 mutations, followed by RAS mutations. And RAS mutations are also common in medullary thyroid cancer. There are a number of other mutations that can be the driver mutation for thyroid cancer involving the receptor tyrosine kinase, such as RET mutations in medullary thyroid cancer, and then fusions of RET, ALK, and NTRK, which are all receptor tyrosine kinases, which can drive other follicular-derived cancers. So when we think about a driver mutation, they are mutually exclusive mutations. So a cancer will usually only have a mutation of one of these drivers. And that mutation alone is sufficient to lead to the development of a cancer. Some of the mutations have weaker oncogenic potential, so especially RAS, so that is also seen in thyroid adenomas, whereas others, such as the BRAF mutation, have a higher level of oncogenic transformation, so that they're not generally seen in benign nodules. In thyroid cancer, there's a number of other mutations that can occur, usually with more aggressive disease, so poorly differentiated or anaplastic thyroid cancers. So classically, that would be TP53 mutations, mutations in the TERT promoter gene, and also PI3K kinase mutations. So going back to our first case with medullary thyroid cancer, so it's important to know that most medullary thyroid cancers are sporadic, and they can, in a sporadic thyroid cancer, it's very common they will have a RET mutation. So a RET mutation in the cancer is not diagnostic of MEN2, but they can, if it is present in the germline, it can cause MEN2. So about a quarter of patients will have MEN2, and so they have a gain of function mutation of the RET receptor tyrosine kinase due to a germline RET mutation. And MEN2 can be classified into 2A and 2B. Both of the subtypes of MEN2 usually have medullary thyroid cancer, which is usually the first disease that is presents in this syndrome. And type 2A, which is the more common type, also has hyperparathyroidism, which generally occurs in the third or fourth decade of life. Whereas type 2B, which is a rarer form of MEN2, does not have hyperparathyroidism, but they have usually a more aggressive and earlier onset form of medullary thyroid cancer. It's important with these classifications to know that there can be quite a lot of inter- and intra-family variability in how these particular diseases present, so at the age and also the stage of the disease. So when you send a patient for genetic testing, for germline testing, this will be done on the DNA looking at the RET gene, and you can see from this figure here, there are a number of mutations that have been described. So for this, my patient in his 20s, he had a mutation in the 634 codon, which is on exon 11, and so that is associated with MEN2A and not MEN2B. So you know with his management that you want to be watching him for primary hyperparathyroidism as well as pheochromocytoma in his ongoing management. The other use of the knowing the particular mutation is it can give you a bearing as to when the medullary thyroid cancer can develop. So for 634, it has been reported in in young children, so between 1 and 2 years old. So obviously for this patient, if he is to have a family or if he has any other family members, this can have implications for them. Whereas MEN2B, it's most commonly associated with a 918 codon mutation, which can be associated with development of medullary thyroid cancer before 1 year of age. Knowing the type of mutation they have and the syndrome, it helps you to know when to screen for other diseases. So usually with screening, so for like my patient, if he had any other relatives, and if for his children, if they were affected, you'd want to screen for pheochromocytoma with plasma metanephrines from the age of 11 years, and similar testing with calcium and PTH for hyperparathyroidism from this age. So the way you do testing is through a blood test. All these patients need to see a genetic counselor first, who will talk to them about the implications of the testing for themselves and also the family. There's also some interest in using germline genetic testing to exclude hereditary disease for patients presenting with solitary thyroid nodules. So in Japan, especially where a lot of these tests have quite short turnaround, they use it to guide the extent of surgery. So that may be something that we see in the future more in our practices. Just moving on to somatic molecular testing. So the main way it's used now is at the moment is diagnosis. So especially for indeterminate or suspicious biopsies, so Bethesda 3 to 5. And the testing is been available in the United States for the last 10 years and is now available in Australia. So it should form part of our discussions for patients presenting with these nodules. The main platform in Australia that is available is ThyroSeq, so that uses DNA and RNA sequencing of around 100 genes, and it can be done of cells taken off slides or tissue blocks from FNA samples, so a special sample does not need to be collected. For this test, it is privately billed, so it costs around $2,000 for the test to be done. And it has a turnaround time around 6 weeks because the samples at the moment have to be sent to the United States. What they look for is a number of those driver genes that I was talking about, and also other modifying mutations in thyroid cancer that suggest more aggressive disease. And with the ThyroSeq test, you get back this report giving you either a test result of a negative or a positive, so negative for cancer or positive for cancer. And also it may give you an idea about the risk of the mutations. So for my patient that had the 1.5 centimeter B4 nodule, her test came back as negative. It was what we call currently negative, so a less than 10% risk of cancer due to having some changes in the number of chromosomes in the cells analyzed, but no other mutations were found. And so she's been followed up with one yearly ultrasounds, and her nodule has actually decreased in size, so she was able to avoid surgery. And these tests generally have been designed for the negative predictive value, and they generally will help around 50 to 60% of patients avoid a thyroid operation. So they do have a role, and it should be discussed with patients when they're making decisions of how to manage these nodules. Moving on to just briefly talking about advanced disease. So all patients with an advanced disease, you should have an idea of what the driver mutation is. This can be done initially with immunohistochemistry. So Anthony Gill and Angela Chow, a pathologist at Royal North Shore Hospital in Sydney, have developed this protocol. So for advanced patients, they perform BRAF, NRAS, and ALK IHC to initially triage a sample. If all those testing are negative, then they send the samples for a limited gene panel, which has about 15 genes, just looking for those actionable different mutations which could affect the therapy. And especially for patients with RET fusion, if there is availability for the newer RET inhibitor medications such as selpercatinib, it can be of great benefit to them. There's also a number of publicly available research projects that are performing sequencing on cancer samples. So OMICO is a group based at the University of New South Wales that has federal funding to sequence 20,000 cancer patients, which could be available to you if you don't have a local pathology service that is able to do this. And if anyone is interested, I'm happy to provide the details for this program. Moving forward, I think the understanding of these mutations will help us predict prognosis and will also help us tailor the type of treatments to the patients with thyroid cancer. And my group and others are doing a lot of work looking on some of these extra mutations and how they affect prognosis. So I'm sure you'll hear about that more in the future. So I hope in this talk I've kind of covered how genetics can be applied to thyroid cancer management. For germline mutations, one of the takeaway messages from this talk is that all patients with MTC should be offered genetic counseling and testing. With somatic mutations, molecular testing for indeterminate nodules is now available in Australia, and it should form a part of shared decision making. For some patients, it may mean that they can avoid an operation. For testing of somatic mutations also should be considered for advanced thyroid cancer to guide systemic therapy, and in the future there will be a role to predict prognosis of thyroid cancer. So thanks for listening. These are my contact details. If you have any questions or want to know any further, please get in touch. Thank you.